2. Now we're moving into exam 3. Okay, so in every exam unit, I always provide a review of the A&P and pathophysiology. So if you're a person that really needs this, I have 2 other pages here, the renal A&P and physical assessment. You can go look at those. I'm going to start with a wet bed. Okay, I'm going to kind of describe a wet bed to you. If you could spend some time learning what the kidney is supposed to do and what happens when that doesn't happen, it's going to help you on this exam. So a wet bed is a mnemonic that tells you the kidney functions. And then I added onto it to tell you what you're going to find in kidney disease if somebody's kidney is not working. And then also the nursing interventions that go with it. Students get really overwhelmed because there's a lot of conditions we're going to talk about in exam 3. But really, if you could just come back to this, it will help you immensely. Okay? So the first thing I'm going to talk about is the letter A, which stands for acid, base, and balance. Or acid, base, balance, I should say. The kidney functions to help us keep our acid, base balance. What you're going to find in people with kidney disease is that they can no longer maintain that balance, so the patient is going to have metabolic acidosis with Kussmaul's respirations, which means they're going to have a low pH and a low bicarb. So what we do for that is, first of all, you're going to correct whatever it is, if you can, okay? Acute kidney injury, you might be able to eventually correct it. But with chronic kidney disease, you may not, only with dialysis for severe acidosis. W stands for water removal. If our kidneys cannot remove water from our body, you are going to see all those signs of fluid overload that you've had every semester, right? All the topics I'm talking about for exam 3, you have had in other courses. So look for those signs of fluid overload, crackles in the lungs, tachypnea, tachycardia, orthopnea, shortness of breath, pink frothy sputum, low O2 sats, the feelings of impending doom, JVD. You're going to see all those signs and symptoms. Okay, so your nursing interventions, we've talked about this before. You're going to increase the head of the bed to high follows first before you put oxygen on somebody, because it's easy to do. If somebody is still making urine, in other words, they're not anuric, you're going to give diuretics. So you can give like furosemide. Okay? If they're not making urine, they may need dialysis. Okay, that may be an emergency. They need dialysis. Morphine, again, is a very good drug in fluid overload or pulmonary edema. Aminophylline, we don't really give that much, but that can also open the airways. Digitalis can help the heart pump more efficiently, or stronger, I should say. So that is something that can help with the pulmonary edema. And fluid restriction. I'm going to go talk about the fluid restriction in kidney disease a little later. Okay. E is for erythropoiesis. Our kidneys secrete erythropoietin to stimulate red blood cell growth in our bone marrow. If the kidney can no longer do that, the patient is going to have anemia, and they're going to need epigen or epoetin alpha. All right. And that's given subcutaneously. I don't know, everywhere I've worked, it's like a scheduled drug, like it comes from the pharmacy. You have to put it in the refrigerator, I think, because there's a street value for it. Athletes use this a lot to boost their performance. So anybody that's going to be on this medication, you have to keep it refrigerated, monitor for headache and hypertension, seizures, DVT, and MI. All right, T is for toxin removal. So if the kidney is not working, you're going to see an increase in medication adverse effects, or you'll be monitoring for that, I should say. For example, somebody that's a diabetic that has end-stage kidney disease, the insulin or oral diabetics are going to stay in their system longer. So you have to check the blood sugar more frequently because they're at risk of hypoglycemia, because the medication is not going to be removed from their system. Okay? They will have a high BUN and creatinine, which leads to uremia. Okay? Now, creatinine is the most sensitive out of BUN and creatinine for kidney injury, and they'll have a low glomerular filtration rate. So the normal glomerular filtration rate is 125 mLs per minute. Now there are variations, and as you age, it gets lower, but that's like our benchmark. 125 mLs per minute or 180 liters per day. Okay? But if you have kidney disease, your GFR is going to be low and your BUN and creatinine is going to be high. So you're going to see in your patient, when you're doing your assessment, you're going to monitor for signs and symptoms of uremia, which I'm going to talk about later. And the patient will be on a low protein diet to prevent uremia. Uremia occurs because of a buildup of nitrogenous products in the bloodstream. In other words, buildup of ammonia. All right, so you're going to see the same signs and symptoms as in liver disease. Okay, B is for blood pressure control. So the patient who can no longer control their blood pressure is going to have hypertension. So it's going to be treated with ACE inhibitors and ARBs. ARBs if the ACE inhibitors cause some kind of reaction, calcium channel blockers, and beta blockers. And what you have to remember, though, about ACE inhibitors is that and ARBs, they can increase potassium, which people who have a kidney that's not working properly are already going to have an increased potassium. So you need to watch that. But they do give ACE inhibitors early in kidney disease because they prevent protein loss from the kidney, in the urine, I should say. All right. E is for electrolyte balance. So people with kidney disease, they can no longer regulate their electrolyte balance. So you're going to see high potassium, which can lead to dysrhythmias, high phosphorus, which can lead to osteodystrophy, which results in low calcium because phosphorus and calcium live in an inverse relationship, high magnesium because they can't get rid of the magnesium, and high sodium, so they'll need a low sodium diet. For high potassium, we're going to treat that with KIND. So that's Kayexalate, insulin and dextrose, sodium bicarb, or dialysis. So, but if your patient has got a high potassium, the first one you're going to do is insulin and dextrose. Okay? That's what we don't really do the sodium bicarb anymore that much. And they may need dialysis. But with Kayexalate, that would come after the insulin and dextrose. You wouldn't give that first for high potassium. All right, with the high phosphorus, we avoid high phosphorus foods. You give PO phosphorus binders with all meals, like Sevelamer is a good one that you see, or aluminum-based antacids. For the low calcium that the patients are going to have, you encourage calcium in the diet, and they may take vitamin D. High magnesium, you want to avoid magnesium-containing antacids, and also magnesium-containing laxatives, because when I start going over diagnostic tests, some of them require laxatives to be given, and you have to check the BUN and creatinine before you can give that. Vitamin D activation. So our kidney helps with vitamin D activation, and when it can no longer do that, the patient is going to have a low calcium level. So patients with end-stage kidney disease or kidney disease have low calcium levels. So the conditions that this wet bed that I've been talking about occur in include the oliguric stage of AKI, acute kidney injury, the oliguric stage of AGN, which is acute glomerulonephritis, chronic kidney disease, chronic pyelonephritis and glomerulonephritis, and polycystic kidney disease when it goes chronic. Uremia. Now, I know you're excited about this. Uremia is another disease that affects every body system, okay? Now, patients with kidney disease are going to have anemia because, first of all, they can no longer create erythropoietin, but also because when you have a high BUN, it can make the red blood cells lyse. Okay, so uremia is not good for blood cells. So the patient is going to feel fatigued, breathlessness. They'll have lethargy and pallor. They'll have a platelet abnormality, which makes them more prone to bleeding. But it's not necessarily that the platelet level is low. It's that the platelets don't work as efficiently as they could. Okay, so it's more of a qualitative versus a qualitative platelet problem. Okay, skin, they're going to have their color in uremia is kind of like a yellow, tan, gray. We call it sallow, SALLOW. Kind of looks like they're tan. They're going to have extreme pruritus because uremia makes them very itchy. In the GI system, they're going to have anorexia, nausea, and vomiting, so VAN. So uremia also irritates mucous membranes. So your patient may have stomatitis, gastritis, right? Because it hurts the mucous membranes. Endocrine, they're going to have, sexual dysfunction. They are going to have peripheral neuropathy, hands and feet. They will have neurologically, they're going to be confused because there's going to be a buildup of ammonia in their blood, just like when we talked about the liver, okay? So what we do about that is we put them on a low protein diet, okay? And then uremia is irritating to the serous membranes. So they could have pericarditis, so you could hear a pericardial friction rub. They'll have pleurisy, you could hear a pleural friction rub. They're also usually going to have hypertension and heart failure. Early on, there's usually no symptoms of like chronic kidney disease. So they may be chugging along and they may notice they have nocturia. That would happen early. It's not until stage 3 kidney disease that things get real, and I'll explain that later. Okay. Edema. That could happen if they're oliguric. The definition of oliguria is 400 milliliters per 24 hours, and anuria is 100 milliliters in 24 hours. All right, so they may have massive edema. And then renal osteodystrophy is due to the high phosphorus, low calcium, so they can get pathological fractures, and so they're at risk for injury. All right, I'm going to talk a little bit about diagnostic tests. So urinalysis, the best time to get it is first thing in the morning. If they have protein in their urine, you shouldn't have protein in your urine. That usually means there's something wrong with the glomeruli, okay? If they have RBCs, it could be a UTI, it could be pyelonephritis, but definitely with glomerulonephritis, they'll have RBCs. Their urine is usually described as tea color, rusty, dark, ketones. Only diabetics should have ketones. Actually, they shouldn't have ketones, but that's when you would see them having ketones. Low specific gravity. There's going to come a point in time where people with chronic kidney disease are no longer going to be able to concentrate urine, and they'll have what's called a fixed specific gravity. It'll be 1010, 1.010, 1010. All right, high specific gravity, we've talked about some of these conditions, and we'll talk more at the end of the semester about SIADH. Leukocyte esterase, that would be present in like pyelonephritis, and that means infection. Nitrates mean E. coli, again, elevated in pyelonephritis. The creatinine clearance is the most accurate way to determine kidney function. Okay, and it mirrors the GFR, so that's the most, but you have to do a 24-hour urine to determine it, so it's not done that often. The BUN is used to detect renal problems, but there's a lot of conditions that where the BUN is elevated. Therefore, the creatinine is probably going to be your most reliable indicator of kidney function. Now, you are going to have to revisit these imaging studies that you've talked about in earlier classes, like a kidney biopsy. So with the kidney biopsy, it could be done under fluoro, but most of the times, maybe not. Okay, so anyways, the most important blood test you have to get pre-op is coagulation studies. The kidney receives 1,200 mLs of blood per minute, which means it's pretty vascular, right? So we don't want people bleeding out having a kidney biopsy. The patient's going to be sedated. You're going to ask the patient to hold their breath while the provider does the biopsy to prevent a pneumothorax. They'll be positioned prone with sandbags under their abdomen and shoulders and during the procedure. So you're going to take your frequent vital signs after. You're going to hold pressure times 20 minutes. You're going to check the dressing for urine and hematuria. They're going to have pink tinge urine for a couple of days, not bloody, but pink tinge. You need to check the H&H. You're going to administer your pain meds. You expect pain at the site. Bed rest could be up to 24 hours. Now, remember I told you the kidney is very vascular. You have to keep these patients on bed rest and quiet, and don't allow their blood pressure to get too high, because then they're going to start bleeding. There's a fibrous capsule that surrounds the kidney. So that's why you keep them on bed rest, because that fibrous capsule can help tamponade any bleeding. All right, and you know what, if they have like Gray-Turner sign, if they have Cullen sign, they could be bleeding, and you know the vital signs for shock, hypovolemic shock. No heavy lifting for a couple weeks. Okay, KUB, just remember no jewelry and check for pregnancy. And they could do this to look for obstructions, like if somebody has a renal calculi or, they have some structural problem. CAT scan. Now, with CAT scan, they can do this to check the blood flow, check the kidney size. But CAT scan is iodine based. And so you're going to have to ask for about a shellfish allergy, which really we don't do anymore, but ATI still says we have to do it, okay? So they are CAT scan given under contrast, with contrast dye. You're going to hold the metformin. Okay, so you need to check all the medications before your patient goes. You need to check the BUN and creatinine and let the provider know. You need to make sure the patient is making urine. They're going to get, to prevent this, if they have a problem, they can get IV fluids, and the flushing fluid is going to be normal saline. It is not D5. D5 is not a flushing fluid, so normal saline. They can get a sodium bicarb 1 amp in a liter of normal saline, or acetylcysteine. That's a drug they can get to prevent them from getting kidney damage. So those are important. So you're going to check the BUN and the creatinine beforehand. All right, so after, you need to monitor the urine output. The goal is 150 milliliters per hour times 6 hours. Like, you want to flush the kidney, okay? Hold metformin times 48 hours post CAT scan. The MRI is similar. The only thing, you don't have to ask about an iodine allergy, because gadolinium doesn't contain iodine. A renal scan is the test they can get that is safe for the kidneys, because it's done in nuclear medicine and they use isotopes, so it's not toxic to the kidneys. So they would do this to estimate the GFR, check the perfusion. That's the safe test. Okay, a retrograde pyelogram, so IV pyelogram. This is to help visualize the urinary tract, and it's iodine based. So you're going to follow the same nursing implications as you would for somebody undergoing a CAT scan. Okay. they're going to get laxatives before they have this procedure. So avoid magnesium containing laxatives, and they'll have an enema on the day of the test. Now, you have to be really careful if older adults get this, because you need to make sure that they're putting out urine. All right. And then with the cystogram, a cystogram, yes, that uses contrast dye, but with the cystogram, you don't have to worry about it being toxic because it's not absorbed. They just infuse it through the bladder and take the imaging, and then the patient points it out. Renal angiography, yes, it's iodine based, so you follow all the same nursing implications of a CAT scan, and then all the nursing implications as a cardiac cath, because they go in through the femoral artery.